and therefore it's a leading US-based manufacturer, and they have their official distributor in Kenya. And this distributor, whom today we are partnering with as the Lab Medicine Society of Kenya, is driving real impact in laboratory medicine. Just a few areas to highlight on matters Intermedica. As you can see, this is a company that manufactures hematology, chemistry, urinalysis, and point-of-care systems, which are known for accuracy, durability, and ease of use. I think you can see some of those equipments on your screen. And the systems are both urban and resource-limited settings, which you can use even within the small dispensaries or within the community level. Another point to note about this Intermedica Limited, Kenya, they are the official distributors of the HTI. As you can see, they provide local inventory, supply chain management, and installation, plus training when they come to, when they bring their products to your facility. And therefore, all this after-sales service they're able to offer. They also offer field service support, troubleshooting, and reagent availability whenever you use their equipment to work. So it's very much important to get to know much about them. We have shared some of their details, and therefore, if you want to reach out to them, it will be of more importance to reach out to us, and then you can connect you to them. Other important points from Intermedica that we need to know is that they give end-to-end diagnostic solutions. Their equipments are high uptime. They also give long-term technical support. They also strengthen lab capacity across the region. And so at the end of the day, you realize that all these things, they improve the patient's outcome. So as we move down, we realize the importance of this particular partner, and therefore we have decided to work with them and ensure that we are able to move as a team. Again, I also need to thank you all for joining us today under Lab Medicine Society of Kenya. You are welcome to this webinar and feel at home as you are going to learn. Our topic for today is quite informative and a very interesting topic that will help us understand much on matters quality. And the topic title is Mastering Clinical Laboratory Quality Assurance. That is the application of the Six Sigma metrics, which is going to be brought to us by Agri Marube. Agri Marube is a renowned scholar in the medical lab, and he's also currently doing his studies at the University of York, that is in the UK, IBMS portfolio. And so he will be bringing today's presentation, which we are going to learn much about mastering clinical laboratory quality assurance. That is the application of the Six Sigma metrics. And therefore, welcome all. I can see our number is coming up. And so we're going to start in a few. Thank you guys for joining. The numbers are good as we move forward. And thank you so much, our team, for joining so that we can learn together. Thank you so much. Much of this information about Intermedica will be able to get when we visit our website, that is the www.lmsk.co.ke. We can write through our emails. We can also get much of this information wherever we talk to the LMSK team. I know we have their numbers around, and so we can always reach them. So we'll be able to get more information. We are also going to share with you and some other partners who have also partners with LMSK to ensure that we are able to bring knowledge and to impact knowledge to the medical profession, especially the lab medicine, the laboratory personnel in this country. And so we are happy to bring all of you on board. As we start this webinar today, I believe our presenter is very much ready to take it away. Mr. Marube is our presenter today, and he will be taking us through this presentation for the next 1 hour, and then we will go for the question and answer session. And so we are also urging everyone to ensure that as you go through this presentation, ensure that you do your questions under the Q&A. As well as he comes in, it's important that we also remind you about our dinner, the LMSK dinner that is scheduled for Friday, the 28th of November, 2025 at Pride Inn Hotel in Westlands. And all professionals, especially the medical laboratory officers, are welcomed to be part of this celebration and this dinner party. So all the details about registration are circulating in our social media platforms, and we are also going to share the details in this particular presentation. The charges are not much. You can access the charges at the link that we are going to share right away. Mr. Agre, I hope you're able to hear me.
Yes, Mr. Fred, I can hear you clearly.
Thank you so much. This is Mr. Arthur, who is standing in for Fred today. And so I'm going to be the moderator, and we're going to have a good time together with our participants today. Agri, thank you for coming. I can see you've shared your screen. I've already introduced you. We request that you just start the presentation. Welcome.
Thank you, my senior colleague, Arthur. I really appreciate for that kind of introduction, and welcome on board my distinguished colleagues, and we learn together. We're going to learn about mastering clinical laboratory quality assurance, and we're going to look at the application of Six Sigma metrics. As you all know that the medical laboratory expertise needs a lot of tenacity to understand what results that we release to help the patients, and also we provide these results so that others can also work safely in their professions. So people need data all around us. They can be doctors, ranging from a number of specialists. They can be nurses, they can be clinic officers, they can be patients themselves. So we should know that we are people who are really valued, and what we release as data to those consumers is key to the wellness of one person who is at the center of it all. That is the patient. So we'll have an overview of Six Sigma metrics by defining it. We look at the data for the Six Sigma metrics. How do we obtain data for Six Sigma metrics? Where is Six Sigma metrics applied? What is the benefit of Six Sigma metrics and the calculations that are involved in Six Sigma metrics? we know that there are also other platforms that we can engage in, especially in quality control and quality assurance programs. However, okay, there are common platforms that we use, especially the LJ charts. We have the scatter plots. We have various analytical processes, especially in data analysis. But we should know also that there is Six Sigma, which is also key, especially when we are trying to check whether the data that we release from our analyzers is accurate or precise. How far is it precise? To what extent is the precision? So that's why we'll find that this topic is going to enrich us as we go along. So the question is, what is Six Sigma metrics? So Six Sigma metrics are statistical measures used to evaluate and improve the performance of a process by quantifying it and quantifying its capacity and defect rate. So here, we are evaluating the performance and by quantifying the capability of this method. And again, we also check the defect rates. And in this, we are using statistical measures. So we need data. Anything dealing with statistics needs data. Six Sigma metrics provide organizations with data to quantify, to identify areas of improvement, track progress, and measure performance in terms of defects passed per million opportunities. That's DPMO. Defects per million opportunities, DPMO. So that is like the standard of measure, and it's the unit of measurement of Six Sigma. So here we are looking at defects, in short. The minimal level of defects, the better the Sigma metrics are. The goal is achieving a Six Sigma level of quality, which is defined as only 3.4 defects per million opportunities. So when we talk of 6, there is 5, there is 4, there is 3, there is 2 and 1. So there are values that we are talking about there. Six Sigma metrics. Six Sigma is a mathematical approach to targets to improve the work process. Six Sigma stands for standard deviation, SD, and Six Sigma represents the possible error of 3.4 defects per million opportunities. This statistically indicates deviation from the goal in any process. If I can give a brief history, since 1999, the Six Sigma method has been in use in maintaining hospital quality management. But it didn't originate in healthcare or hospital environment. It originated from somewhere, especially in production and engineering. However, since 1999, it was adopted into healthcare settings and has been used even in the laboratory settings. But what I'm sharing is customized for the laboratory settings. So in the past years, the Six Sigma method has been successful in implementing various laboratories to assess performance. A Six Sigma is considered an excellent and a real-world class standard. Values less than 3, that means less than 3 sigma, are considered satisfactory. And the levels that are less than 2 are unsatisfactory and should not happen anywhere, especially in the lab. So we have that ladder that indicates sigma range from 1 to 6. We see in sigma 1, there are 691,462 defects, 691,462 defects. In sigma 2, it's almost half of sigma 1, which is 308,538 defects. In sigma 3, we have 66,807 defects. Sigma 4 has 6,210 defects. Now sigma 5 has 233 defects. Sigma 6, only 3.4 defects. So we can see a range of values, and they are decreasing drastically from sigma 1, which is the highest, and the least is sigma 6, which is the highest world-class standards we can obtain. So when you get values in your medical laboratory setting, and you subject these values, maybe over time, maybe 6 months or 1 year, especially in EQA, or IQA values, maybe for 10, 20 days or a month, and you subject them to 6 sigma calculations. When you fall under 6 sigma, this means that you have 3.4 defects. So your methodologies and their functioning, your methods, your data integrity and the data that you produce is of a real world-class standard. So that's why this is very important. LJ cannot show you whether you are world-class standard or not. Scatter plots cannot help you much, although to some extent they can help you. But 6 sigma can help you understand which standards are you in. Are you below standards? Are you considered satisfactory? Are you excellent? So data needed for calculation of 6 sigma, there are 3 major data sources. We get data from total allowable error. These are maximum acceptable error for a test, often based on biological variability, which defines the performance limits. We have imprecision. Imprecision means the reproducibility of a test. Typically, it's expressed as a coefficient of variation or a standard deviation. This data is derived from internal quality control results. If I can briefly state, total allowable error are usually ranges that are usually given, they are standard ranges that are usually given by clinical laboratory improvement amendment authority in the US. That's CLIA, CLIA. If you go to the website for CLIA, you'll get the data for total allowable error. And I'll be ready to share it because it's in the presentation. The third source of data is bias. Biasness is the trueness of a test method, representing the systematic difference between the laboratory results and the true value. So what is the true value? And what value did you get in your analysis? So there are 2 values, there are 2 data sets there. The value that you got in your analysis and the true value, the true imaginable value. This is often calculated using EQA programs. We also have peer group data or reference materials. So data can be acquired from reference materials that when you analyze a certain sample, especially the samples that are given by manufacturers, they have their true values. Those true values are the targets that we should look for, especially when we are doing analysis with our equipment. and we check the biasness from that true value. So we have variance also. Variance is the issue of variability in test results caused by combination of biological factors, natural differences in a patient, and analytical factors. Issues in testing process also come in to play. It's a critical concept for quality control and is measured using tools like the coefficient of variation. These are mathematical principles, maybe from a college understanding of mathematics, statistics. So there are sources of variations. We have biological variations. This is inherent variability in a patient's biological states. Patients' biological states can be maybe activity or inactivity, the time of day, like the circadian rhythm, the time, maybe the time after maybe consuming food or meal or taking something, time after maybe taking a drug, and the associated metabolic activities that are associated with that. Those are biological variations. And there are a number. And these are taken into consideration when analyzing a test. That's why they are crucial even in pre-analytical phase of our testing. So we have also within subject variations. How much a specific person test results fluctuate over time due to factors like diet, sleep, and time of day. Yeah, this is also related to biological variation, but this is within subject variation, how these test results fluctuate over time. Maybe you've gotten the sample, and this sample, there are issues like blood sugar in this sample, issues like lactate, which are very volatile. How do you store it? How do you, when did you analyze it? What, when you repeat the test, what, after maybe 3 or 4 times, how are the results behaving, and what causes those variations? Yeah, this is what we need to ask ourselves within subject variation. So there is between subject variation also. These are natural differences in results across different individuals in a healthy population. We've done maybe tests over a range of patients, a range of maybe age sets, and there are normal limits for each age set. But in each age set, maybe you've done 10 samples. There are variations, even if these are healthy population, there are variations in this. These are between subject variations. We also have analytical variations. In analytical variations, we look at the testing process itself. How is the testing process behaving? Now, in pre-analytical, variances or errors, these are errors that occur before the sample is tested, such as improper patient identification, incorrect sample collection or storage, and issues with additives or sample volume. So these are things that we all know, and these are things that we should consider when doing analysis. So when explaining precision and imprecision, we have this analogy. Look at those dartboards. The dartboards. We have the precise analogy, that first dashboard, and also that first one, the first dashboard, dartboard indicates that the results are accurate because all of them are in the bullseye. In precise, in the second bullseye, in the second dartboard, we have imprecision. That there is only one result that is in the bullseye, others are scattered all over, but they are within the second circle. And again, the second circle is a circle of accuracy, of acceptance. Outside that, there is imprecision or inaccuracy or complete inaccuracy. So the third cycle or dartboard indicates inaccuracies, and even the fourth one. But the third one indicates quite precision, even if the results are inaccurate, they are precise. The fourth one indicates total imprecision and total inaccuracies. So when we look at that, those dartboards, they give us a lot of learning on the way our equipment or our instruments are functioning. We can have data in one side of the target, consistently in one side, but falling within maybe the acceptable ranges. Yet, maybe we've not checked our calibrations, and we qualify it under LJ charts. We failed to subject it to Six Sigma metrics. When we look at the precision and the imprecision and also accuracies. Now, this one will lead us into making grave mistakes, and we find ourselves flawed, especially after receiving our EQA results. We find ourselves failing, and yet when we used to analyze our internal quality control controls, we used to pass very well, and our maybe EQA results, IQA, internal quality assurance results, were at par the standards according to the LJ charts. But when it comes to Six Sigma subjection, they are failing. So we find Six Sigma to be superior to other methods of analysis of data, of quality assurance data. So how do we manage and how do we interpret variation? So we interpret variations through running quality control. Laboratories implement quality management programs to monitor and minimize analytical variability through methods like running controls or control samples and using statistical analysis. We don't just run controls, but we also subject these results to statistical analysis. We also look at coefficient of variation, a common metric used to measure variability. So it is calculated as standard deviation divided by the mean. So these are statistical methods. So we have formulas, and we all know, we've gone through a number of mathematical courses, and we know these things. So coefficient of variation is done. That's standard deviation over mean, and then you multiply by 100. You get it in percentage form. So a lower coefficient of variation means that there is a less variation. You see, these are standards of measurement of central tendencies. So we check how variability, how much do values move away from the target or from the mean. And we are given reference intervals, and in this reference intervals, laboratories can establish reference intervals based on a large population. Don't take a minute population for you to establish reference ranges. You better use manufacturers' reference ranges if you don't have robust data. Variations must be understood in the context of these intervals, in the context of reference intervals, yeah? And more importantly, a patient's own previous results can also be scrutinized. There are also individualities among tests. Some tests, the variation is within an individual is much greater than variation within the population. In these cases, a person's baseline is more important for tracking changes than the population-based variation. Let's talk about defects. In a clinical laboratory, a defect could be a false positive or a false negative. Now, any error that deviates from the acceptable standard also is a defect. Sigma metric expresses on a scale of 1 to 6 represents the number of standard deviations between the process mean and the nearest specification limit, e.g., total allowable error. Total allowable error is a specification limit that's given and is a tested value from methodologies that be, especially in the international standards arena. So these total allowable errors are available, as I said earlier, especially from CLIA, and CLIA documents are the reference documents that we need to use for getting total allowable error. And this gives reference ranges for every analyte that we are working on in the laboratory, so long as it's a quantitative analysis for this analyte. And question that we need to ask ourselves, how are Six Sigma metrics applied in labs? Labs calculate Six Sigma as the Sigma values using 3 key parameters: the total allowable error, imprecision, and bias. And these are applied in benchmarking. The Six Sigma metric allows labs to benchmark their performance against established standards and other labs. That's why, especially in EQA, you are given data from your peer groups, the peers. What did your peers get? And what was the Z score of your peers? The Z score of the analyte? Yeah, so that you can compare yourself with the reference labs, especially under EQA. The Six Sigma metrics are also used in optimizing the QCs. Labs can use Six Sigma or Sigma values to optimize their quality control strategies, including selecting appropriate QC rules, frequencies, and control materials. The Six Sigma can be used to reduce, to reduce errors by identifying and addressing process weakness. Labs can significantly reduce a number of errors in test results. They can be used to improve efficiency. Also, optimized QC strategies can lead to more efficient use of resources, such as QC materials, and reduce the time spent on troubleshooting. Yes, you've subjected your data to Six Sigma metrics, and you found that you have been in error maybe for the last 1 month, but your QC materials, depending on how you subjected the data, shows you that you are right all the way. What of if after some time, maybe 10 days, 15 days, you've been subjecting your data to Six Sigma metrics, or all along since maybe January this year, you've been regularly subjecting your QC results to Six Sigma metrics. QCs, that is IQA and EQA to Six Sigma. Don't you think you'll be always calibrating your equipment when the time is due? You realize that maybe your equipment are malfunctioning, and then you take prompt measures to make sure that these equipments are serviced, corrective maintenance is done before problems go far. So this is what we mean by optimized, reducing errors and time spent on troubleshooting. We have also enhanced patient safety. Fewer errors translate to more accurate diagnosis and better treatment decisions, ultimately improving patients' outcomes. Here, we can also save the costs. As I've stated before, especially in regular analysis of Sigma metrics, we'll be knowing how our equipment are trending. So we can reduce errors to a great extent and save costs, especially on QC materials. And when the equipment break down, there is less troubleshooting because these errors are detected early in advance before the equipment breaks down. So the role of IQC and EQC in Sigma metrics. So here we realize the importance of doing EQC in conjunction, especially in analyzing the quality performance of our laboratories in conjunction with IQC. One checks the other. So quality control measures in a clinical diagnostic laboratories at the analytical level primarily involves routine performance and assessment of internal quality control and also external quality control. For this purpose, the participation in quality control programs, preferably as conducted by third-party providers. Third-party providers, I mean the external quality assurance partners who will provide the analytical control materials that are required for you to analyze in the lab. So in Sigma metrics, Sigma metrics offers a valuable framework for medical labs to enhance quality and efficiency of their processes, leading to improved patient care and optimized resource utilization. So in Six Sigma, we have data integration, meaning that we can bring data from one source, we can bring data from another source, we combine together, we analyze this data together. So individual parameter performance is expressed in terms of Westgard rules and Z scores. You remember the Westgard rules we used in LJ charts, and also the Z scores for internal and external quality analysis respectively. The Six Sigma not only integrates IQC and EQC data, but also identifies the existing gaps, thus improving laboratory performance. What do you do after encountering defects in Six Sigma calculation? Defects, maybe you are performing below 3 Sigma, you are not even in 5, you are below 3. What do you do? Those are significant defects that you should consider working on seriously so that you improve. First of all, you have to identify the root cause. You analyze the data, review process data, and investigate to determine the cause and defects, the cause of the defect, sorry, and you take corrective actions. So in corrective actions, you have to adjust the processes and implement changes. Before I go far down that list, we need to look at, when we identify the root cause, there are so many things that we look at around. You look at the entire process from patient preparation to sample collection, to sample transportation to the lab, the sample, maybe the sample storage. You look at the environmental factors in the room, in your lab, temperature charts, can be ambient temperatures, they can be fridge temperatures, and so many things. And the expiry of your reagents, and again, how long has the reagent, for how long has the reagent been opened? So there are so many things that we look at, especially in looking for the root cause. After analyzing all these data, we come to a conclusion that, and pinpoint that this is the problem. And maybe the problem is, for example, great variations in temperatures in the laboratory environment, whether it's in the fridge or ambient temperatures. So what do you do with that? You evaluate now, check, compare with your analysis with the reagents that you have, and the new reagents that were brought on board maybe a day before or 2 days before, so that you can check the variability between the old sets of reagents and the new ones. Do you need, maybe your freezer is not working well? Do you need to make new aliquots because the ones that were there have been affected by temperature variations that are inconsistent with the requirements? What do you do? What is the standard practice in your lab? What are the protocols? After aliquoting maybe a control or an EQA sample, for how long do you leave it in ambient temperatures? Or for how long do you need to thaw and freeze it? Do you use once and discard? So those are questions that you need to ask yourselves. And this is whereby you now swing into corrective actions to correct what has been done in a wrong way. And in this, you retrain the staff to ensure that personnel understand the new procedures. You update your SOPs, revise the standard operating procedures, and make every other lab personnel understand these procedures. And that means that they should be accessible. You then you go into preventive actions. After correcting everything associated with that anomaly, you go into preventive actions. Now you implement quality control measures and enhance monitoring. And here you have to apply regular audits. Audits are key. Remember, the other day we talked about audits. Audits are very important. You continue to conduct regular internal audits to make sure that everything that was corrected is implemented. The way you trained your staff, they are implementing everything as per the SOPs that you trained them on. And then you embark on continuous improvement. You encourage ongoing quality enhancements, and you encourage people to use Six Sigma metrics. So also there is verification. You recalculate the Sigma to verify improvement as time goes by. Maybe in a week's time or 2 weeks, you embark on Six Sigma subjection, and also you monitor your performance, you track the progress. So as you've seen earlier, now we are going to the nitty-gritties of the data that's required for Six Sigma metrics. We'll look at the calculation methods for precision, how we collect that data, and calculating the mean. These are issues that we all know, but now we collect data by running quality control, and we get data from there. We can pull patient samples or multiple times, and after pulling them, we run replicates per day. We can run those replicate those results, the results that are there. We get the data of the results for maybe over 20 days. We see the variability within that data set for 20 days, depending on the protocols that we can use. Some of them prescribe a month, maybe sometimes 15 days, but that data has to be robust. You don't take just a few samples and say 10 samples and say that you have data. Have sufficient data for you to analyze. Then from that data, you calculate the mean. And this is how Six Sigma is calculated. Now we have data for total allowable error, TEA. We have data for bias. We also have data for coefficient of variation. The three parameters that we should have in Six Sigma calculation. Now that data will help you to using that formula to calculate. Where can you find where to find CLIA TEA limits? That is Clinical Laboratory Improvement Authority TEA limits. So you go to CLIA official website and you check proficiency testing guidelines and survey procedures. You'll get the resources there, and those resources will include the data and the reference ranges for the TEAs, the total allowable error values for each analyte you are working on. So the website link is given there. It will help you. So basically, that's where we get our TEA limits. So the CLIA, or Clinical Laboratory Improvement Amendments or Authority regulations specify total allowable error limits for various laboratory tests, defining the maximum acceptable error in a test results. These limits are crucial for ensuring the accuracy and reliability of a patient test results, and laboratories must meet these performance goals. Let me tell you the importance of using total allowable error. For instance, you are running a lab and you find yourself not having the requisite laboratory quality control materials. You don't have, and your protocols dictate that you must run controls and validate those control values and make sure that they are authentic and they have passed before you release patient data. What do you do? Do you stop analysis that day? What do you do? Now this is where we need total allowable error. You can take the 3 samples from previous analysis, yeah? Those samples, you rerun them like let's say yesterday you ran three samples yesterday evening or afternoon. Those are samples that are kept nicely as per the standards. You run them today using the same methodology, the same machine, to check its performance, the same machine that's lacking quality control. And also you can also check your quality control, whether they are performing well. So you run the test, you repeat the test, you rerun, and check the variability between the two analyses using total allowable error. If the total allowable error values pass, then you are good to go. You are ready to defend yourself, your performance, the performance of your lab according to the TEA values and the calculations there. If they reach a pass mark, that is just by the way, it's important for you to consider that, because these things happen. Sometimes we lack controls. What do we do? So that's something that you should consider. It's acceptable. But never run tests without any control measure, any quality control measure. The analyzers, the machines will misguide you, and you find yourself in trouble. So the data for the metrics, the bias refers to systematic error in a measurement. I've stated the bias, I've explained the bias before. The systematic error. It indicates how far from the average repeated measurements deviate. We can remember from that data board what we saw, especially in that board 3, how the results were concentrating on one point of the circle, and at the periphery of the limit, they were precise but in error. So that is bias. It can be expressed as an absolute value or a percentage. The coefficient of variation is a measure of imprecision or variability of a test, expressed as a percentage of the mean. It reflects how much the results vary around the average. So Six Sigma is data-driven methodology focused on reducing defects and variation processes. That's how we calculate the standard deviation. That's a simple calculation that we all know. And currently, it's very important for us to use computers. This formula, you can place it in a computer, and you put values and they calculate themselves. So you need to be tech savvy so that you understand how you can do your statistics in the computer for your work to be easy. And also, Six Sigma can be done in the computer. I'll not be able to show you step by step the algorithms that are required for you to calculate and also draw a normal distribution curve for Six Sigma. But you can check the algorithm using artificial intelligence, and you'll get the algorithms on how you can calculate and also draw a chart for Six Sigma metrics. Coefficient of variation is simple. We know standard deviation over mean times 100. When you look at that normal distribution curve, we see how that one can help us, Six Sigma can help us in identifying our process and scrutinizing whether we are in error or not. Look at those defects. When defects cross the limit lines, and you see the deviation from the true value, that true value in the middle, the bias. Look at the coefficient of variation. Now we have another value that's not true. maybe in quotes, I can say untrue value. And the coefficient of variation, now this value that you've gotten, the variation around that true value in quotes, untrue value, also can be calculated. Now look at how we can identify those defects in that chart, the normal distribution curve. Look at those normal distribution curves and how they behave. Look at the curves, the series of curves, especially in image 1. Look at the 6 sigma on that blue normal distribution curve. Many values are close to the central value for the 6 sigma. For the 4 sigma, there are values close to the central line, which is the true value or the nominal value, but some of them, many of them there are a number of them that are far away. In 2 sigma, many are far away and few are close to the true value. And again, look at the upper specification and the lower specification. So if a normal distribution curve crosses the upper specification, that cross, at the point of that crossing, everything beyond that crossing is a defect. And that's what we are trying to avoid. The far away of the normal distribution curve is away from the upper specification limit or the lower specification limit, the better it is, the higher quality it is. So the closer we reach at this 6 sigma matrix. Those curves can explain themselves. Look at the 6.6% defects and that deviation, especially from the central line, which is the nominal value, the target. Look at this value, the last normal distribution curve, how it is good. The 6 sigma process, it's really good. And the highest standard of performance without defects. The curve is not even touching the upper specification limit. So this is what we anticipate for. Okay, look at those curves. Look at the shifts, how you can identify the shifts. In a nutshell, if you look at this, like especially when you're doing hematology, there are machines that usually give this distribution, normal distribution curves, and there you're able to judge and those curves and look at the left shifts and also the right shifts, especially left shifts for immature cells. You'll be able to, those curves really help. Those are the sigma metrics in application. Scatter plots can also be used. The sigma metric scatter plots are often used to visualize the relationship between two variables, showing how much one variable is affected by the other. It shows trends and patterns. Yes, I've talked of a hemogram machine and how the trends are, how cells are distributed around the mean that's expected, how they have shifted to the left or to the right of the target, or the reference range. Okay, the reference targets that have been set by the machine or by calibration These Six Sigma scatter plots help to reveal trends, patterns, and outliers in data that might not be obvious from raw numbers. It can show relationship. You see, if you have so many dots that are along, maybe along or distributed along a certain line, just draw, you want to draw a line of best fit. It will show you a scatter plot like the one that we have. Scatter diagrams are also important because they also replicate. They replicate also the sigma matrix, and they help us to check our data and for us to be able to validate. By plotting two variables against each other, you can see if changes in one variable corresponds with changes in the other. Validating assumptions, especially when scatter plots are used to check assumptions of statistical models, such as linearity. These are also things that we use, especially in research, apart from also besides laboratory use, clinical laboratory use. They are valuable tools for Six Sigma analysis, helping to identify correlations and patterns within data. Scatter plots display how closely data points cluster around a line, indicating the strength and direction of a relationship. Is it a positive relationship or a negative? Are there values that are below the target, or there are values that are above the target? So we check all those. Are there values that are on target? So how many values are there? So that's how you check the precision. So that's the end of our presentation. I really appreciate the LMSK. This is an invaluable platform for every medical laboratory professional to be able to engage and learn. Thank you, Arthur. Back to you, my senior colleague, for this, for maybe questions and answers and also comments. I really appreciate.
Thank you so much, Mr. Agri. You've given us a very informative presentation. I will request that you still project your presentation, the second page. Kindly, you do us the second page. And I'm going through the charts from our participants: Elizabeth Mbuvi, Sarah Wangari, and many more. Isaac Onyango, Michael Kamau, Collins from Mombasa, Charity Mwendwa from Mombasa, and so many of us. Now a question from Titus Mutua to Agri, and the question is, how can someone achieve precision? And I don't know if you will understand it, but the question is, how can someone achieve precision when it's within RAN? I don't know if you're able to understand that question, but that is the question. Maybe probably wanted to write something different, but it's a question connected to that kind of wording. Are you able to maybe give say a word about that, about maybe precision during maybe running over test and all that? Able to give something back to you, Agree?
Okay, precision within RAN within RAN precision. Now, this is the data that's obtained from maybe repeated analysis of the same analyte. with the same sample. So you run and check I think I described it before. When you take a sample, a pooled sample, and you subject it to tests for 20 days, and you obtain data in all those 20 days, and you subject this data to Six Sigma metrics. And this is run within run precision. It will help you to see how your machine is behaving. Are there deviations from what you expect, or what is really happening with the machine? And most often we don't use, especially unless the labs that are not using EQA. You can subject your EQA analysis to all those number of times. That is run within run precision. It will help you and guide you to get the data that's enough for you to ascertain the performance of your analyzer. And after getting that performance, ascertaining that performance, whether it is a flawed performance or it's a perfect performance, you'll be able to make relevant decisions. Thank you.
Yeah, thank you. Agree. Another question comes, and the question is, you tell us something about true value, and if it is the same as establishment value. You can tell us what is a true value and if it's the same as an establishment value. Back to you.
Okay, thank you. The true value is the value that has been released by maybe an organization that is credible, can be the manufacturer, and ascertained to be the true value. Because by research and using the analyzers that are up to date, that meet all the standards, all the necessary standards for a certain period of time. These machines must be tested for a considerable time for it to qualify to be a reference, method for analyzing that analyte. And when the value has been obtained, this value is subjected to an average, and this average is given. And the limits also are given for this value. Let's say if it's calcium, you are told that this calcium from the manufacturer, this control must range between this and this. The upper limit is maybe 2. Okay, the upper limit maybe is 6, and the lower limit is 2. And you are given the average of 4. That's the true value. It's now the average and the target value. So when you run your controls, they must be as close as possible to 4 for them to be qualifying, for them to qualify as to be within standards. If they are far away, most of the values that you do in repeated analysis, replicate analysis, or run within run precision, you continue running that same sample for some time, and you subject it to Six Sigma, you find it deviating from the true value. And that deviation also goes beyond the upper limit and the lower limit. That's where you find the deviations or defects, especially in Six Sigma. And when you start seeing those deviations, you'll be sure that your method is failing. Thank you. Back to you.
Yeah, thank you. Agree. Let me check if we have any other question to tackle. Any additional question to tackle? Let me check. There's a question from Electin. Shilewa, and the question goes, what is the acceptable deviation in any given run? Back to you. Agree?
Yes, acceptable deviation means that there are deviations from the mean that you are given, or the true value. However, these deviations don't count much because they don't go beyond the upper limit. They don't go below the lower limit. They are closely associated with the true value. And when they are closely related to the true value, you also check on the bias, because the Six Sigma also has a component which is bias, a component in its calculation. As we said, the Six Sigma uses the TEA, that's total allowable error, which is a standard of measure that's given by authoritative bodies like CLIA. We also have a calculation of bias, and we also have a calculation of precision. All those three major components of Six Sigma will give us a normal distribution curve to see clearly whether that curve is touching the upper limit or is touching the lower limit. And again, checking the bias. What is the deviation? Even if all the parameters have passed and the values are concentrating close to the mean, is there a deviation or is there a biasness to the positive side or to the negative? Are values concentrated on the negative? You see, when they are concentrated to the negative, that's also a concern, and that your machine is maybe having a defect, is tending towards maybe failing, tending towards failing, towards the negative side or towards the positive side. Biasness is also a key ingredient. Even if all our controls are passed, it's a key ingredient that we should check. That's why LJ charts cannot help us much, especially when it comes to checking those values. Even if we see certain trends, the normal distribution curve in Six Sigma is so helpful in looking at those values, whether their deviations are acceptable. We look at the biasness, that's the shift from the mean, either to the positive side or to the negative side, or they are well distributed, both sides, either lower and upper side. Using reference data from reference bodies like CLIA, and the data that we obtain, especially in the analysis. I hope I've answered that too.
Yeah, thank you. Thank you for the answers. Another question from Calvin Okech, and the question goes, when test is performed under routine condition of work, what happens to degree of variability in CV? Back to you, Agree?
When, can you repeat?
When test is performed under routine condition of work, what happens to the degree of variability in CV?
Degree of variability. Now, you see, CV calculates the standard deviation. The CV coefficient of variations, sorry, it calculates variations within the data that has been obtained. When these tests have been done under normal conditions, that means everything remains constant, maybe everything is okay, and the coefficient of variation, what happens to the coefficient of variation? Now, when everything is okay, maybe under standard conditions, the coefficient of variation, okay, maybe I don't understand the question very well. maybe that question needs to be reframed from the origin. Maybe Calvin needs to clearly reframe the question so that we can understand it.
Somebody is responding here, but maybe you can also weigh in. And this is Titus Mutua, Rina, and he's saying, standard deviation and CV are different. We need to understand that the smaller the CV, the precise it is. Maybe you can say something about that.
Okay. That is true. The standard deviation, the smaller the standard deviation, the more precise it is. The more precise the analysis is. Also, the coefficient of variation, the variability is usually measured under the standard, the coefficient of variation. No, the standard deviation, sorry. That's the coefficient, that's the variability within a sample. What about the coefficient of variation? The standard, sorry, the coefficient of variation. What does it measure? The coefficient of variation is usually measures the relative variability, meaning that there is something that we are considering. We are trying to compare, because the coefficient of variation is usually standard deviation over the mean times 100. It measures the percentage it's measured in percentage value. The low coefficient of variation means high precision too. What does it mean by high coefficient of variation? It shows poor precision. Also, the high standard deviation will indicate poor precision. The same applies to, or biasness. The same applies to coefficient of variation. Both are related, but one can be used to check biasness, and the other one can be used to check variability or precision.
Thank you so much. Another question from another statement, also it's a statement or a question at the same time from Edwin Okwemba, and it is, in the absence of low controls and high controls, is it okay to only run a normal control for the machine, e.g. a full hemogram machine? Maybe you can make a comment on that.
Thank you for that question. And now, when you're running controls, and it is okay to run two controls. It's advisable for you to run two controls, although many labs run 3, but don't rely only on one control. Either you can use normal or high, or normal and high. You can use normal and low. You can use low and high, but it's important for you to consider that because low and high are tending towards abnormals. Avoid using the two together. So we see how normal is important in quality control, internal quality control. So, but if you are unable to get the normal, it's acceptable, but don't keep on relying on that for a prolonged time. Make it as brief as possible. But when you have 3 controls, it's also acceptable for 2 to operate. And again, maybe advice due to using data from experience and my understanding from experience, is good for you to keep on interchanging. You maybe sometimes you run or you interchange between low and normal and high. Low, normal, normal, high. Low, normal, normal, high, so that you compare their performance as time goes by. Maybe this is because of maybe the costs. You're trying to mitigate the costs. It can help you. But in limited circumstances, use low and high only.
Thank you. Thank you. Let's look at our last question. And the question is from Benedict Omondi. And the question goes, what's the difference between shift, drift, and trend in quality control? What's the difference between shift, drift, and trend in quality control? Back to you.
Yes, let me start with drift. Drift is a gradual progress towards a defect. Maybe it's a measure. It's a measure of variability showing bias. It's a systematic error that's developing, but it's developing slowly. A shift is a large variability showing a large difference from your previous run, and is moving to a greater extent, and you're seeing that it's closing to an error. So there is large variability. So it's a drastic change in your values. It might be coming from a negative standard deviation to a positive standard deviation, almost approaching the upper limit. So that's a big difference, and we call it a shift. And it's usually a random error, but a drift is a systematic error. And again, a trend is closely associated with drift, because these are values that are moving in a certain direction, but they are moving slowly over time, and you're able to notice that there is something going to be wrong. You can almost predict on what's coming in the future. So a trend is a little bit more prolonged than a drift. So that's how I can answer that. Thank you.
Yeah, thank you so much, Agri, for the presentation you've been able to bring to us today. I also would wish to thank our partner, and I'm so excited to spotlight a partnership that is currently transforming access to modern and reliable laboratory diagnostics across Kenya and the entire East African region. That is the Intermedica HTI, which is a leading US-based manufacturer, and currently they are operating in Kenya. And they are one of the partners that are ahead of time to ensure that LMSK is able to deliver the very best for the medical laboratory fraternity in this country. We are so grateful for this company, and I believe we are going to move forward and do great things on behalf of this profession. Another company that we wish to spotlight again that is also partnering with LMSK is Ketones Limited under Dr. Jack Odul. They've also come in handy to ensure that we are able to achieve the aspirations of medical laboratory professionals in this country. Another partner that we also will wish to spotlight is Flowman Healthcare Limited, the best solution in medical products. They are also doing well in ensuring that they are able to partner with us and ensure that we are able to grow our profession together. And lastly, before I bring back Agri to say his parting shot, is that I would wish to urge every medical laboratory professional in this country to attend our Friday dinner summit that is scheduled to take place on the 28th November 2025 on Friday as from 4 p.m. to 10 p.m. Kenyan time in Westlands, Nairobi, Pride Inn Hotel. And so we have keynote speakers, very powerful speakers in matters healthcare and matters medical laboratory services in this country. And therefore, this platform will give us an opportunity to face to face and one-on-one meet most of our respected personalities in this profession and beyond, and we'll be able to network and achieve a lot within that span of time. So we urge you all to get into the links that we are sharing and register and make sure that you are able to attend in person. Otherwise, I'm looking forward to see you again tomorrow. But before we adjourn this, let me bring back our presenter to give us his parting shot before we adjourn. Back to you, Agri, for your parting shot.
Yes, thank you, Arthur. My parting shot is that ensuring that as medical laboratory technologists in the field of laboratory medicine, our quality means our quality tenacity means life and death to people, to humanity. So if we do it well, we bring life back to normalcy, and we can save lives. Without ensuring safe practice and quality practice, we'll be driving people on the other direction, and we will be endangering lives of many people. So these programs are very important for us to learn and apply them in real life situations. So thank you and God bless you. Hello, back to you. I hope
Oh, thank you. Yeah, thank you, Agri, for this very educative presentation you've done on behalf of LMSK. And from my seat, I'm so grateful for our members, our partners, and our presenter for making sure that today's webinar has been a success. We are planning to do another webinar tomorrow, and I believe that we will be attending again so that we can learn together. For the purposes of the dinner summit that we have on Friday, we also urge that we continue registering so that we can attend early enough. Otherwise, thank you so much, and see you tomorrow, same time, 3 p.m. to 4:30 p.m. And I wish you the very best this evening. Thank you.